Friends, good evening. So I'm going to discuss today about endoscopic therapy of gastroesophageal reflux disease. So is it ready for the prime time? So what is GERD? Gastroesophageal reflux disease occurs when the amount of gastric juice that refluxes into esophagus exceeds that of the normal limit, causing symptoms with or without associated esophageal mucosal injury, that is esophagitis, and its complications. So many a times I see people using double dose proton pump inhibitors as treatment for GERD. But unfortunately, GERD is not a disease of hyperacidity. So it's a motility disorder. It's a dysmotility disorder. So starting from reduced salivary bicarbonate to reduced esophageal acid clearance, impaired mucosal defense. So with impaired lower esophageal sphincter, that is increased transient ileus relaxations or reduced basal tone delayed gastric emptying, and then what is called a duodenogastro-esophageal reflux. All could be components of gastroesophageal reflux disease, which means PPIs are not the all and end all in the treatment of gastroesophageal reflux disease. And that is why most of the patients, respond, but some percentage of them will not respond just with the PPI usage. So we have to stratify the gastroesophageal reflux disease patients into three types. One is based on severity of symptoms. Two, recognizing those with atypical symptoms. And three, recognizing those with possibility of developing complications. These are the guys which you have to be very careful and probably require more aggressive therapy. So stratifying patients on severity of symptoms, there are three clusters of symptoms that have been documented: inconveniencing, distressing, and disrupting. 1/3 of all GERD is disruptive GERD, which means with the higher prevalence of severe and reflux symptoms, more frequent, disturbing the sleep, and risk of future complications. So this group has to be really the disrupting group, or the disruptive GERD requires special attention and treatment. So based on the typicality of symptoms also, you can classify them into typical symptoms and atypical symptoms. Typical symptoms could be heartburn, regurg, nausea, vomiting, early satiety, and dysphagia. So, but atypical symptoms could be non-cardiac chest pain and asthma, pneumonia, hoarseness of voice, and aspiration. If you see the extraesophageal manifestations starting from otitis media to asthma, sinusitis, erosions of the teeth and aphthous ulcers, and halitosis, pharyngitis, laryngitis, laryngospasm, postnasal drip, frequent throat clearing, globus, tracheobronchitis, chronic cough, aspiration pneumonia, pulmonary fibrosis, bronchitis, bronchiectasis, non-cardiac chest pain, sleep apnea. All this could be extraesophageal manifestations of GERD. One should remember in the OPD when we are seeing. So that is why many of these patients go to dentists or ENT specialists, pulmonologists, cardiologists, and then finally come and land up with the the gastroesophageal reflux disease experts, namely the gastroenterologists. So we know the typical symptoms are heartburn and regurg with or without esophagitis, the atypical symptoms that I showed you, but the complications can ensue in some of them with esophageal erosions, ulcers, stricture, Barrett's, and esophageal adenocarcinoma. All these are absolutely preventable complications. And so stratifying patients based on the probability of developing complications is of three types. One is a non-erosive reflux disease, the NERD, which is the vast majority, 60%. 35% will have demonstrable esophagitis at the time of endoscopy. 5% may even present for the first time with complications. So, or they may progress to complications. So this group can progress to more complications than this group. So we need to be aware of this, stratification, which is important in choosing which patient will develop complications. So the goals of treatment are to control symptoms and to heal esophagitis, because the patient comes to you for his complaints, not for the diagnosis or the disease. So you have to control the symptoms and heal the esophagitis, keep the esophagitis, maintain the healing. and to prevent recurrent complications of esophagitis and other complications. So, starting with lifestyle modification and control of gastric acid secretion and egress into esophagus is the paramount important components of medical therapy. So, you all know the lifestyle intervention, pharmacologic therapy. I would use a PPI prokinetic combo rather than even just the PPI, especially in the Indian scenario with the high spices and masala items that we use. Of course, the disruptive group or people with atypical symptoms, people who are likely to progress to complications, all these people need definitive treatment in the form of surgical or endoscopic interventions. That's what I'm going to address you today. So let us look at some of those case scenarios. A 35-year-old gentleman who came with burning chest pain of 9 months duration. The pain was more in the night after food. Many of the PPIs are not that effective in the night dosing. So they are best when you give it half an hour before breakfast. So this patient was on PPI for 3 months but still not happy. So we took him off PPIs for 7 days. We put him on sucralfate and also antacids like alginic containing antacids so that the 7 days are bridged. And then we took him up for endoscopy, manometry, impedance paciometry. This is what we found, a large hiatus hernia. So naturally, he is not happy just with the PPIs. And you see here, he had reflux grade C, Los Angeles classification of reflux esophagitis, so which is with erosions. And so we did the manometry and impedance paciometry. So you see here, this is a normal manometry. This is upper esophageal sphincter, lower esophageal sphincter. The peristalsis is going through the body of the esophagus. And whatever is in pink or black is high pressure, blue, green is low pressure. So this is the body of esophagus. So here, as the LES, UES opens, the LES also opens and the bolus goes through. And the LES pressures are really good, so that it acts as a barrier to prevent reflux. You see here in this patient, the lower esophageal sphincter is here and the diaphragmatic pinch cock is very weak here. So it's a double layering indicates hiatus hernia and disrupted peristalsis and low pressures of LES. So hypertensive LES with hiatus hernia and hypertensive peristalsis is what we found. Even the esophagus, the length itself is slightly shortened. You look at the impedance pH. So anything that comes below the dotted line means significant acid reflux into esophagus. You see here in the middle of the night between 1:15 and 3:15 a.m. the patient has significant reflux. Again, some more reflux post-lunch starting at 3:15 to 4:15 and 5:15. So you see here this Demeester score or the composite score, which looks at the totality of the reflux in upright time and reflux, recumbent time, total time, episodes over 5 minutes, longest episodes and total episodes. The normally the Demeester score or the composite score has to be below 14.7. You see here it is 85.1, which means significant acid reflux and for staying for prolonged periods, and the longest episode was beyond 3 hours, 197.9 minutes. So we put them on PPI plus etopride, and then again eloprazole at night was useful for nocturnal acid suppression. Patient became better symptomatically in combination with alginic containing antacids and also sucralfate. But then we needed something definitive, so fundoplication was definitive. So total Nissen fundoplication was 360-degree wrap was done, and the patient ever since remained free from use of PPIs. The second case was a 50-year-old gentleman with 10-year history of retrosternal burn, symptom not relieved with PPI therapy, and there was no hiatus hernia, but he had a columnar-lined esophagus. So on biopsy, it turned out to be Barrett's metaplasia and an early dysplasia, mild dysplasia. So this is what we found. So patient had symptom relief with PPI etopride combination. However, it was not perfect. And then we needed to ablate the dysplasia. So we just took him up for radiofrequency ablation. This is Halo 90. So very simple. So you just, press the pedal and scratch over the mucosa of the esophagus. It just gets whitened out and the tissues are completely ablated. So that's the beauty of this technique. So it's a very safe technique, the Halo 90. And then we took him up for a definitive procedure to which is the anti-reflux mucosectomy. which is an endoscopic mucosal resection. So what we do is we just mark 2/3 of the circumference. The Japanese take 85% of the circumference. We inject, saline with indigo carmine, and then we raise the blebs, and then use the cap and the snare, which just seats beautifully inside, and then we just suck and then cut. So this is endomucosal resection. So we cut 2/3 of the circumference on the gastric side from the fundic side and take away mucosa like this. So, and we should have always a coag grasper, because there could be large vessels which could bleed. So we should be prepared. So we just removed all those, cut portions, and then, like use coag grasper to control the bleed. And then 2/3 of the circumference is cut like this. So this is described by Professor Inouye. So, and then we complete the resection, endomucosal resection, and spray collagen. The collagen helps in producing a barrier against acid. Pepsin allows healing. So these are the steps of the anti-reflex mucosectomy. Again, 2 weeks later, I called this patient again, sprayed collagen over the unhealed areas. So that accentuates the fibrous tissue generation there. And see, this is a pre-procedure, and the post-procedure, see the augmentation of the LES pressures. And again, the impedance, you saw the D meter was 47.3 before procedure. After procedure, it came down to 12.1. So which is normal. Less than 14.7 is normal. And again, the waveform, this is pre-procedure. Below pH 4, all these indicates acid reflux into esophagus. Here, you see, for the majority of the time, it doesn't have reflux. So the pre-arms, and this is the post-arms after the RF ablation, the columnar lined esophagus, especially the Barrett's dysplasia, is completely gone. So this is a study by the Japanese on anti-reflux mucosectomy, which appeared in 2019, and where they said no hiatus hernia patient should be taken, lax ileus is acceptable. Either use a band EMR or a cap PMR. We used a cap PMR to do this procedure. So they have left 15% of the circumference only, whereas we had left 2/3 we had taken, and 1/3 of the circumference we had left. Even that is working well. So this is the procedure. Then we'll move to another case, a 46-year-old lady who came with reflux disease, and then rabiprazole etopride combo for 2 years. And patient had abdominal pain off treatment and also irritation in the trunk and belching, wanted a definitive therapy. So this is how it looks. The lower esophageal sphincter in the, this is normal. This is the patient. It's not too bad, but still the patient had the composite score of 33.3, indicating significant reflux. And so this patient wanted something definitive. So we just, this is again the reflux symptom index is called SI, 58% correlation with all reflux, and this is SAP, symptom association probability index, which is 100% correlative of all reflux episodes, which is very important in impedance. So this patient, we are sure, will get relieved from his symptoms once the acid surge into the esophagus is prevented. So this was the impedance graph, and this is how it looked on endoscopy. It was not a hiatus hernia, slight laxity of LES, that's about it, and nothing else. So we just took up this patient for a procedure called Gerd, and this is the first procedure done in BGM Hospital. Dr. Nageshwar Reddy was performing this in our unit. So this is how it opens, the jaws open, and then the spiral screw comes out, and then you attach it and draw the tissue towards the device, and then the device closes, and then we apply the plate jet. So this is you pass the device and retrovert, get into a J maneuver, and then you just check under fluoroscopy whether things are okay, and then you pass the device. The device is a very thick device, so fluoroscopic control you have to pass it in, because it has to get into the cricopharynx, because it's the diameter of the device is large, so you have to be very, very careful. So 18 millimeter has to pass through, so you have to be very careful. So this is how we get in, and then you just draw with the spiral, you pull the tissue and then release the platelet. So this is how it works, and you can see after we deploy 1 or 2 platelets depending on so how much we need, we can deploy. So that's about it. So this is a good procedure, very easy, and the patient is absolutely off PPIs and doing well. So a brief about endoscopic techniques for treating gastroesophageal reflux disease. Nearly 1/3 of with medically refractory GERD will desire an additional non-surgical treatment option. So endoscopic anti-reflux therapies have been available for over 2 decades, but are not part of routine GERD management because of the initial safety concerns and lack of efficacy. Recently, the endoscopic therapy has been reintroduced as a minimal invasive anti-reflux barrier treatment after addressing the prior efficacy and safety concerns. Over the last 2 decades, additional experience and new technologies have resulted in devices and protocols with favorable short-term and long-term outcomes and safety. So the plication systems and the radiofrequency ablation are the 2 types of endotherapy. The plication systems, the TIF is number 1, then comes the Muse, and then the Gerd. This is transoral incision-less fundoplication is TIF. Medigas ultrasonic surgical endostapler is the Muse, and Gerd is the third one which we saw just now. The stretta went out and came back again. And there's a beautiful article, 2018 current opinion on endoscopic techniques for treating gastroesophageal reflux. So this is the ESOFIX or the TIF, so which has got a similar pattern. So we just retract, plicate, secure, reduce. That's what it does. And this is the Muse, so the Medigas system. And then this is the Gerd, and this is a stretta where you just produce a thermal injury, and then this causes fibrosis and apposition of the wall. And then look at the short-term results. The TIF, 6 months, 97% PPI free. Again, the D-Meester score is minus 9.7. All of them have worked, but you see here, 6 months PPI free. The best was TIF, then Muse, and then only the Gerd and stretta. And you see here the PPI-free remission over, this is the almost like 50 months to 60 months, 5 years. And it is 100%, nearly 100%, somewhere around 90s is TIF. So then comes the Muse, and then the Gerd, all of them almost sailing in the same boat, about 50 to 60% success rates, along with stretta. So BARD was the beginning of this suturing device, which we started way back in 2002. I did only 7 cases the end of suturing and left it because even though theoretically the whole muzzle layer, the propria layer would get drawn into this window here, it doesn't happen in reality. Only mucosa, submucosa gets sucked. So this didn't work well. So it has gone off the use, and the plicated device is one such. And so there are so many devices now available. And out of these, as I told you, TIF is number 1, Muse is number 2, and Gerd number 3. Stretta will be number 4. So finally, my friends, so are we ready for prime time in endotherapy for GERD, especially the disruptive GERD, where we suspect these guys can get into complications, or atypical manifestations of GERD, which really patients' quality of life suffers? Endotherapy can be done. And yes, we are ready for prime time use because we have now almost like 4 to 5 year data. People who are off PPIs, close to 90% in TIF. So the key points here are the 2 categories of endoscopic anti-reflux devices in the market are RFA and endoscopic plication. Long-term data for endoscopic anti-reflux treatments demonstrate durable subjective improvement that's comparable to anti-reflux surgery. The overall serious side effects or adverse events is low today with the newer systems of the devices which are coming, and safety concerns appear to have been addressed by newer devices. Future research should include long-term objective outcomes, that's the esophageal acid exposure, and also for newer devices, sham-controlled studies with ongoing safety assessment. I thank one and all of you for this patient listening, and thanks for the opportunity given.